Harry S. Truman Library at Independence, Missouri, is the scene of an historic event. President and Mrs. Johnson and Vice President Humphrey arrive for ceremonies that will make the Medicare bill a part of Social Security coverage. Mr. Johnson chose to sign the bill here as a tribute to former President Truman. The former president campaigned for Medicare 20 years ago, but it took 2 decades for his proposal to become law. The new bill expands the 30-year-old Social Security program to provide hospital care, nursing home care, home nursing service, and outpatient treatment for those over 65. Medicare will become law on July 1st, 1966, and for Mr. Truman, an historic souvenir from the president. For Mr. Truman, the passage of Medicare is a dream come true.
No longer will older Americans be denied the healing miracle of modern medicine. No longer will illness crush and destroy the savings that they have so carefully put away over a lifetime so that they might enjoy dignity in their later years. No longer will young families see their own incomes and their own hopes eaten away simply because they're carrying out their deep moral obligations to their parents and to their uncles and their aunts. And no longer will this nation refuse the hand of justice to those who have given a lifetime of service and wisdom and labor to the progress of this progressive country.
"1965 could be described as the best of times and the worst of times. Family income rose by 5%, while prices increased by less than 2%. Unemployment was slightly more than 5%. The average price of a new home was less than $22,000. A gallon of regular gas was 31 cents. A first-class stamp was 5 cents. And the average cost of a doctor's visit was slightly more than $6. And for some analysts, an ominous monetary development occurred. Silver was removed from U.S. coins. The American economy seemed to be firing on all cylinders, but on March 7th in Selma, Alabama, state troopers attacked several hundred civil rights demonstrators in what has become known as Bloody Sunday. Teach-ins were held throughout the country on college campuses in response to U.S. policy in Vietnam, and on November 27th, tens of thousands of Vietnam protesters picketed the White House and then marched onto the Washington Monument. On August 11th, riots broke out in the Watts section of Los Angeles. And on November 9th, a blackout in the northeast region of the country and a part of Canada lasted up to 13 and a half hours. On the political and legislative fronts, 1965 was one of the most important years in post-war America. Historic legislation was passed, guaranteeing voting rights, creating anti-poverty programs, spending more federal tax dollars on transportation and housing and rural economic development, among other initiatives passed by Congress. Overseas, President Johnson committed the first phase of sending troops to South Vietnam, even though he did not ask Congress for a declaration of war. Eventually, more than 500,000 troops would be stationed there by 1968. Some historians and others have argued that the country experienced a political, social, economic, and even cultural transformation in 1965 that is still reverberating in America today, a half-century later. Coming off a landslide victory against Republican presidential nominee Senator Barry Goldwater in November 1964, President Johnson, on January 4, 1965, in his State of the Union address, outlined his administration's Great Society goals. One of the cornerstones of LBJ's Great Society vision was Medicare, a federal taxpayer finance program with modest premiums to provide health care coverage for the elderly. On January 7, 1965, President Johnson outlined his ideas about expanding the federal government's role in medical care, in a special message to Congress, advancing the nation's health. Our first concern must be to assure that the advance of medical knowledge leaves none behind. We can, and we must, strive to assure the availability of and accessibility to the best health care for all Americans, regardless of age or geography or economic status. With this as our goal, we must strengthen our nation's health facilities and services, assure the adequacy and quality of our health manpower, continue to assist our states and communities in meeting their health responsibilities, and respond alertly to the new hazards of our new and complex environment. Getting Medicare passed in 1965 was not a slam dunk for Democratic President Johnson, even though the Democrats had huge majorities in Congress after LBJ's 1964 landslide victory. He had to overcome the opposition of powerful conservative Southern Democrats who chaired influential committees in the House and the Senate. And there is considerable evidence that LBJ deliberately lowballed the future costs of Medicare to get his legislation passed. Prior to the passage of Medicare, about 50% of the elderly had private hospitalization insurance. Today, nearly all Americans over the age of 65 are covered under Medicare's Plan A for hospitalization. Over the past 50 years, Medicare has expanded substantially, adding more and more benefits, despite the original premise that medical coverage for the elderly would be a modest program that would not become a major burden for taxpayers. Medicaid, signed into law with Medicare on July 30, 1965, provides health care coverage to millions of Americans, including eligible low-income adults, children, pregnant women, elderly adults, and people with disabilities. Medicaid is administered by states according to federal requirements. States and the federal government fund the program jointly. Both Medicare and Medicaid began as relatively low-cost programs to deal with the health care needs of the elderly and the poor. Nevertheless, projected Medicare and Medicaid costs were substantially below actual costs. In 1965, congressional analysts estimated that Medicare would cost $12 billion in 1990. Its actual cost that year was $110 billion. The hospitalization program alone was supposed to cost $9 billion, but wound up costing $67 billion. These are not small forecasting errors. Fast forward to today. Federal spending for fiscal 2014 totaled $3.5 trillion, with net spending on Medicare, that is Medicare spending minus income from premiums and other offsetting receipts, comprising 14% of the total. Spending on Medicaid, along with spending on the Children's Health Insurance Program and exchange subsidies, represented 9% of federal spending in 2014. In the future, Medicare outlays are projected to increase nearly twofold, from $527 billion in 2015 to $981 billion in 2025, an average annual growth rate of 6.4%. These estimates do not take into account additional spending that is likely to occur to avoid reductions in physician fees scheduled under current law. Medicaid enrollment has increased from 4 million in 1966 to 70 million today, while spending has increased from less than $1 billion in 1966 to more than $430 billion. Based on current projections, by 2025, Medicaid will spend more than $1 trillion, with the states picking up half that amount. What do policy experts and physicians think about Medicare and Medicaid? According to Boston University economist Lawrence Kotlikoff, one of the nation's leading experts on the federal budget, the federal government's accounting of its future obligations leaves much to be desired.
Well, Medicare and Medicaid and Social Security all have big expenditures projected in the future, vast expenditures. The baby boom generation is 78 million in size, maybe 77, 79, depending on how you count it. They're all going to be collecting benefits from these different programs, or almost all of them. And those obligations are sure things. They're not on the books. They're not recorded as part of the government's debt. So we have all these expenditures into the future, and then we've got the tax projections for covering those expenditures. And if you look at the difference between these two, if you take all the projected expenditures from now till the end of time, based on numbers the Congressional Budget Office puts out, and value those expenditures in the present. So that's what we call present value. If you had to pay it all off today, what would it be worth? And then you compare that with the present value of all the taxes. And the gap between the two, which is called the fiscal gap, is $210 trillion. Now, Medicare and Medicaid are a very big part of that problem. But how much you say is due to those programs versus the other programs is a bit of an accounting game. You could say, well, Medicare and Medicaid are in fine shape because all the federal income taxes and all the payroll taxes are really allocated, in my mind, to cover those programs, and it's the other programs that are short of funding. So there's no real way of saying which particular program is the problem. What we do know is that the expenditures as a group are far beyond what anybody's right now willing to pay for, and therefore what we're doing is we're leaving an enormous bill to our kids. So we're doing all this off the bookkeeping. The fiscal gap right now is about $210 trillion large. The official debt, the obligations that are formally recorded, they represent only $13 trillion. So you have the true problem, the true debt of the country is $210 trillion. The reported problem is $13 trillion. So the difference between these two numbers, which is almost $200 trillion, is what Congress and administrations are hiding. That's the degree of lying. That's a direct measure of the degree of mendacity that we have in our fiscal accounting. So this is the big problem here, that we're lying to ourselves, we're lying to our kids, and we're leaving our kids in terrible shape because somebody has to pay these bills.
David Knowlton, president of the New Jersey Healthcare Quality Institute, provides us with his perspective on Medicare.
We have a curve of escalation in cost, and that curve is both in drugs and in care. And as we get the baby boomers getting older, an increasing proportion of them are falling below poverty levels. And even those who aren't falling below poverty levels are paying increasing amounts out of pocket. So I have a hunch without some system of protection that they would be in trouble. You also have the fact that people get on Medicare and they're living much longer. And so when people are dying in their 60s and 70s, it's a different problem than when they're dying in the very old in their 90s and getting up to be centenarians. No question about it that we got it's a perfect storm. You have 10,000 people a day in America turning 65, a day, and they will be doing that for the next 15 years. So that's 10,000 a day that are moving into an age group which shows heightened morbidity. Nothing predicts morbidity like age, unfortunately. So we've got these people going in with an incredible illness burden, and we've got escalating costs going through the roof. So yes, we're going to have a problem. The other part of that question is, who says that 85% of what hospitals are getting now is not sufficient to provide the care that needs to be provided? You know, I think we're going to see hospitals short stays, people not staying a long time. I recently had a laminectomy in my back, which is a major spine procedure. And I looked it up before I went because I'm in health policy. I looked it up on the web and said, oh, I'm going to have a 3 or 4 day length of stay, general anesthesia. I went in at 7:30 in the morning. I had general anesthesia. I was out by 4:30 in the afternoon. I went and did a staff meeting and went home and took 2 aspirin and went to work the next day. Now, that's great for me, okay? But that wasn't great for the hospital that I was at. That 4-day length of stay meant that, and it was done in really an outpatient basis, meant that they walked away from probably $15,000, $20,000 worth of reimbursement. But that trend is a positive trend and something we should embrace. I think that's what we're going to see. We're going to see more of that.
About 1/4 of all Medicare spending goes to pay for the care of beneficiaries in their last year of life. And much of the growth in Medicare spending in recent decades is a result of high cost of treating chronic disease. How should end-of-life issues be dealt with?
Conversations of a lifetime are encouraging people to make their wishes known. You have this irony that nobody wants to be sitting in an ICU with tubes in every orifice and in pain, and that's the end of their life. Nobody would choose that, except if their wishes aren't known, there's no way to act on that. And so we did a seminar on this one time at the Institute with a syndicated columnist from the New York Times, Pauline Chen, who also is a trauma surgeon, a transplant surgeon. And the question I asked her, much like you're doing today, I was the questioner, and I said, Dr. Chen, we're gonna buy you 30 seconds at a Super Bowl, because it was Super Bowl weekend, the next weekend. We're gonna buy you 30 seconds at the Super Bowl. What would you say about end of life? And she really got puzzled. She thought, and she finally said, I would say, if you love someone, you owe them the gift of clarity.
Meanwhile, how are doctors and patients affected by Medicare's rules and regulations?
Medicare has not been terrible heretofore. Federal government is now getting into the practice of medicine, telling us what to do, what not to do. And it was exactly what Edward Annis predicted way back in 1962 when he railed against the whole idea of the federal government taking over the health care of the elderly, because they promised that they wouldn't get into the hospitals, they wouldn't be telling doctors what to do, they wouldn't tell doctors what to charge. And instead, now they're getting into every little nitpicking area and telling us this is okay, this is not okay. And pretty soon the houses of mercy are going to become something else, and it's something that could be very dangerous for patients. Physicians are physicians. We've been allowed to take care of patients. We've probably done too many tests on patients that are on Medicare, which possibly wastes a lot of money, and that's partly to do with our malpractice system. But so far, Medicare patients have not been harmed by the system. I can't say that that's going to be the case going forward as they try to rein in costs and cut down on what is paid for. I haven't seen that doctors have refused to take Medicare patients. Many are opting out completely, though, and they just don't like the administration and all of the paperwork of the Medicare system. So, plus, if Medicare finds that you've billed wrong or done something wrong, there is there's huge penalties that can that the doctor can incur, and so doctors are becoming fearful of the federal government.
As a non-participating physician, Dr. Copeland does not receive direct payment from Medicare. Instead, she bills the patient, who then has to obtain reimbursement from Medicare.
Because it's not the money, it's the freedom. And I've been putting up with it thus far, but it's going too far now. Now they want everything to be on computer. Now they're telling the doctors that you must keep things private, and then they make it impossible to keep things private. So it's not a program that I would vote in at this point in time. It's something that we have to work to try to put in its place and allow senior citizens to be human beings like we all are. The traditional insurance that we have been used to has presented us with a reasonable deductible that is well affordable. And so the patients can use that going to see a doctor, knowing that future payments are going to be picked up by their insurer and that they can afford to have this done. However, Obama has turned it upside down, and he has put such a high deductible up front in order to make it less expensive for the government to be able to fund things, less expensive for the insurance company to be able to fund things, that the patient winds up with a bill that is really almost unpayable for most people. So they're given the choice of buying the Obamacare type of insurance or having the choice of going bare and not taking insurance at all because they can't afford the private insurance that has a $6,000 deductible in front of it. Because they cannot afford those high deductibles and they cannot afford to pay the insurance company for the high deductible insurance in most cases. So the doctors are sitting without work. And so many of them are discouraged that many of them just want to leave.
While most doctors still accept Medicare patients, some doctors are no longer participating in the Medicare program. One physician, Dr. Pamela Weibel, outlined her objections to Medicare in 2014. Medicaid has been hailed as one of the most important programs of the federal government. It pays the health care costs for eligible poor families, the blind and disabled, and children. All told, about 70 million Americans receive Medicaid benefits at a cost that is fast approaching $500 billion annually. Children account for nearly half of all Medicaid enrollees, but just 1/5 of Medicaid spending. Only 1/4 of Medicaid enrollees are seniors or persons with disabilities. But because these beneficiaries need more and more costly health care services, they account for nearly 2/3 of all Medicaid spending.
One of the big problems with Medicaid is the incentives to work, the disincentives to work are horrendous. If you earn too much money, you lose Medicaid. And you can earn just an extra dollar, and all of a sudden you and your family are no longer covered, you have no health insurance. So this is a big impediment to working, or at least working in the formal sector, and therefore paying taxes. This is one of the worst designed systems in terms of labor supply incentives that you could actually come up with. Everywhere you look, you have these impediments, these disincentives to work for the poor. So regardless of what kind of health care Medicaid is delivering, and I think that's been a problem in terms of the quality of the health care, the quality of the Medicaid nursing homes, the quality of Medicaid being provided to low-income workers and families. Even apart from that, just the way it was designed in terms of giving people this benefit, but then clawing it back in such a aggressive way so that people really have no incentive to work at some point or earn much money at all. That's a terrible sin, and politicians have let this go. You would think that the people that hate the poor could not come up with a better system of healthcare delivery than this.
So Medicaid is broken, but part of the problem with Medicaid is we don't fund it adequately to do the job that we ask it to do. So I love Uwe Reinhardt when he did that, Professor Reinhardt from Princeton, when he spoke to the New Jersey legislature on the commission that he headed. He said to the legislature, you feel that a person on Medicaid is worth this much less than a person on their own insurance, and the legislators got very offended. And he said, I'm an economist. I believe we make value decisions by where we place money. And he says, that's what you're doing. I'm not saying whether it's right or wrong, I'm saying that's what we're doing. And so Medicaid is that type of system. And it's broken. It's broken in New Jersey. It has been for a long time.
Part of the problem that we have in healthcare is that we're using insurance to pay for oil changes in our car. If we did that, insurance would cost so much more. We're using insurance to pay for just the most routine of visits. And that is just not a reasonable way to do, that's not insurance, that's prepayment of health care.
I think the government can play a role, but it has to be a modified one. It has to be a role in which bureaucrats do not pretend to be physicians, in which the government does not tell a physician what to do and how to do it and whether to do it. It has to be just a background of helping people who can't quite afford the expense of medical care as it has evolved, which can be very expensive. Hospitalizations are very expensive. Hospital administrators earn millions of dollars a year. You know, it isn't doctors who are earning the high money, it's really the hospital administrators who earn more. And this all figures into how much an insurance company is going to have to pay per patient when they become ill. If the government can limit its role to helping those patients who really can't afford not being with the government, and let there be some kind of a deductible, or let the doctors not charge for a portion. Be reasonable about this so that everybody can receive health care. Then I think it can work.
Our panel of experts has given us their perspectives on the challenges both Medicare and Medicaid face after 50 years. Currently, both programs pay for the medical needs of more than 140 million Americans. What are their recommendations to deal with the healthcare needs of the elderly and poor in America?
Now, there's another solution. In Oregon, the governor took the amount of money paid on Medicaid, rank ordered it by procedure, and said, we'll fund to this level, above this level. So if you're on Medicaid and you're over 65, you're probably not going to get a liver transplant. Because he said it's not the best stewardship of state purchasing power. Now, very controversial, but what I'm not sure how I feel about the whole thing, but I have to say that I thought it was more rational. I think legislators would like to say, we don't ration care. Sure we do.
What we need is what I call the Purple Health Plan, and one can go to the web and look at the purpleplans.org. And the Purple Health Plan, I wrote a book called The Healthcare Fix, which discusses this plan, but it's very, very simple. It says, let's get rid of all these programs, which are fiscally out of control. They're all costing the government more than our kids can pay. And let's just start from scratch. And the idea is very simple. You give everybody a basic health care plan, and you do it by giving everybody a voucher. And it's going to pay entirely for the basic health care plan. So if a person here has diabetes, he gets a voucher, but the voucher is based on their pre-existing medical condition, and it's good for a year. So I give person Joe here a voucher, and it's quite large because he's got diabetes, a pre-existing condition. He gets a big voucher. Sally over here gets a small voucher. She's perfectly healthy. Joe and Sally take their vouchers to the health care insurance company of their choice. They buy the basic plan. Now the insurance company is on the hook to cover their medical care over the course of the year based on what is covered under the basic plan. A panel of doctors would decide what can be covered, such that the total cost of all the vouchers doesn't exceed 10% of GDP. Joe's basic plan and Sally's exactly the same plan. If they need to get a broken arm fixed, they'll both be getting that fixed. The cancer treatment, same treatment. But now let's think about the incentives of the hospitals and the insurance companies. They're getting a fixed amount each year to cover people. And now they're going to have an incentive to hire doctors, build hospitals, and internalize all the costs of providing the care, because they're not going to get any more money for providing the basic care. If they do a poor job, a year later, Sally and Joe take their vouchers and go to a different health insurance company. Whether you're poor or rich or old or young or black or green or whatever, you're all Americans. Everybody needs a basic policy. We need a system that doesn't drive the country broke. So we need health insurance, but we need to provide it in an efficient way that doesn't drive everybody broke and doesn't provide the doctors and incentive and healthcare industry ways to game the system. So if the voucher is fixed and that's all the insurance company gets, that's that. And the fact that Joe is going to get a bigger voucher because he's got diabetes and Sally's got a smaller one means that the health insurance company has no incentive not to take Joe. So Joe's going to be compensated for his bad information. We're going to solve through this individual specific voucher the key problem with health insurance, which is adverse selection. The fact that the insurance company doesn't know whether Joe's got diabetes, but now they will know because it will be very clear from the voucher and from the electronic medical records of Joe what the insurance company is taking on. But also the insurance companies will not be allowed to turn anybody down.
To address the medical care needs of low-income residents in their respective communities, Dr. Jean Cheslak founded the nonprofit Parker Family Health Center in Red Bank, New Jersey.
To be a patient at the Parker Clinic, you need to be a Monmouth County resident. You need to have an income, you need to fall into our income requirements where we'll take patients up to 300% of the federal poverty level. And most importantly, you have to have no insurance, private nor public insurance. They're completely uninsured.
It's not easy to get volunteer doctors and volunteer nurse practitioners. It's a wonderful model, but we struggle. For a while we struggled with not having enough doctors, so we had to reduce our patients coming on board. It's a wonderful model, but there are some issues with it.
One of the reasons the volunteer model works for us and for many volunteer clinics is because we fall under the Health Resources Services Administration's malpractice immunity. It's called the Federal Tort Claims Act, FTCA. The federal government provides malpractice immunity for any person volunteering in our clinic to provide these medical services. But for free clinics, that stipulation is that you can accept no reimbursement, no private reimbursement and no public reimbursement. So we are, in order to maintain our malpractice immunity, we may accept no reimbursement.
As far as a model for the rest of the country or for any community, ideally it is the model for any community, but it's limited by the affluence of the population around you and its ability to support a place like this, besides all the other wonderful not-for-profits in Monmouth County. There are over 1,000. So the competition for the buck is huge.
We are very fortunate at the Parker Family Health Center that we have about half of the providers that are volunteering there as specialists. It's astounding, honestly. So we have about 50 physician APN providers, licensed independent practitioners that are seeing patients, and about half of those, a little bit less than half of those are specialists. So within our walls, we have a strong primary care contingent, but then I have almost every medical specialty represented there. So we are able to do a lot more within our walls than we could even with just primary care providers. I can have them, if a patient has a problem, I can get them to see a cardiologist, I can get them to see a pulmonologist, I have a dermatologist, and it's amazing, I have an endocrinologist and a rheumatologist. I mean, these are incredible specialties to have housed within one practice. So it's a very interesting mix of primary care and a multi-specialty clinic.
You know, those outcomes and that good maintenance of say a diabetic, the decreased frequency of visits to the emergency room is a tremendous saving to the system. If you look at our cost per patient, which is roughly $100, and you look at the cost of a visit to an emergency room in our area in Monmouth County, which probably averages about $1,300 or $1,400, you can see the savings very quickly.
In Somerset, New Jersey, Doctors Alida and John Eck created a faith-based voluntary nonprofit, the Zarephath Health Center. Both centers rely on the volunteer services of physicians to provide medical treatment for their patients.
Very early on, we stopped taking Medicaid patients, and that's probably 20 years ago, when we realized that after we would do all the paperwork and all the sending in for the Medicaid system, the amount that we would get back would be less than the cost to provide care, and we'd be essentially taking care of them for free. So we pulled out of Medicaid very, very early on. And instead, we started a non-government free clinic 10 miles away where we could take care of the poor for free there. One thing we do is we'll take the time to do what we need to do without feeling the pressure of having to bring in enough money to pay all our overhead and get paid ourselves. So when you hear everybody volunteering, it's just volunteer time. It's fine. You know what? The Health and Human Services or the Senate Health Committee right now is debating whether people should be able to change their birth certificates. If they were born a male and they want to be a female, they want to allow people to change the gender on their birth certificate, which I think is a birth certificate is a historical document. What you want to be now and what you were shouldn't change. You shouldn't be able to go back and change your birth certificate.
You were born that way.
That is the kind of thing, though, that they're dealing with, which to me has really no impact on the actual health of a patient.
Right.
Why is the health committee debating that, or who's going to do the EMS services for a given area. Or they want to have children under 13 to be allowed to get a psychiatrist without the parents' consent. That's another one that they're trying to push in New Jersey. Instead of a really common sense healthcare reform law that would lower the cost, increase affordability of healthcare, would increase access to care, and would not fleece the taxpayers.
And get better outcomes.
And get better outcomes. The reason why there aren't a lot of clinics is because there's just not enough of an incentive or something for the physicians to do it. There still could be sued for malpractice if the patient would come to their office. And plus, the practice of medicine is becoming much more difficult. It's hard to earn a living in medicine now. That there's just many, many reasons why the doctors are being. The practice of medicine is just more difficult. It's a business, and if you're not getting reimbursed enough, it's difficult. So the thought of volunteering is just beyond their abilities. So we don't really have that many volunteers in our clinic. That's why we need some kind of more of an incentive. So, I mean, that's our goal, to make people self-sufficient, not to get them into a program for which it's extremely hard to escape.
After hearing our experts, what is the future of Medicare and Medicaid? First, let's set aside the observation that the U.S. Constitution does not authorize the federal government to pay for the American people's health care or subsidize their medical insurance. So, what have we learned from the 50-year Medicare and Medicaid experiment? For the proponents of Medicare and Medicaid, both programs have been resounding successes. They argue many more people today have medical coverage because of the passage of Medicare and Medicaid in 1965. However, we do not know how medical coverage for the elderly and indigent would have evolved since 1965. Isn't it just possible that today we would have a less costly, less bureaucratic, higher quality healthcare system without Medicare and Medicaid? As the chart shows, out-of-pocket healthcare spending has plummeted since the creation of Medicare and Medicaid. This phenomenon has created what economists call moral hazard. By delinking the payment for services, patients tend not to value that service as much or overuse it. In addition, as out-of-pocket spending has declined, federal and state spending, in other words, taxpayer dollars to pay for healthcare, have skyrocketed since 1965. For some physicians who see medicine as a calling, they are reinventing their practices to provide high-quality, low-cost care to their patients. One such physician is Dr. Pamela Weibel. Dr. Weibel is a leading advocate for what she describes as ideal medical care, a medical practice designed by patients. In a recent telephone conversation with Dr. Weibel, she made the following points. Government should back off primary care. Let healers be healers. We do not need more legislation to regulate health care. Medicare's tens of thousands of regulations are strangling the practice of medicine. Doctors should get paid for their services from their patients, even if it is a nominal amount. There are too many unnecessary tests performed. Third-party payers, insurance companies, and government have distorted medicine. And finally, let doctors do their jobs instead of spending most of their time doing paperwork. There are many proposals to address the long-term financial shortcomings of both Medicare and Medicaid. But in the final analysis, we should have a national conversation about healthcare in general in the context of a much broader question: what should the role be of government in a free society? Okay? Finally, if war is too important to be left to generals, then given the financial challenges and less than optimal outcomes of both Medicare and Medicaid, the 50-year experiment should lead us to the conclusion that healthcare is too important to be left to politicians and bureaucrats.